So what I'll do now, and Dr. Pravda will really discuss all of the science, but I'll go over the history with you and then show you the studies. The first one is a 46-year-old white female diagnosed with ulcerative proctosigmoiditis in '03. She was initially treated with prednisone and acecol. She had a good response, but never developed a complete remission. Ultimately, acecol was increased to 4.8 grams, and she clinically improved. By the way, can everybody see this? Yeah. Everybody has it on their screen. Good. By '05, she was having normal BMs, but flexible sigmoidoscopy continued to show active disease. Roesa enemas then were begun. In '06, on acecol and Roesa, flexible sigmoidoscopy showed a normal mucosa. She did well for a year, but then symptoms recurred in mid-year while she was going through a difficult divorce. She was then treated with acecol, Roesa on demand, Xanax, and in '07, I saw her and scoped her. Let me show you her endoscopy. I think you can see that. Where's the little? Yeah. I think you can see the marked inflammation that she has, and this is the rectosigmoid. And then when I put my scope up to about 40 centimeters, show that last one. So, it is completely normal. So what we will show you are the biopsies, the initial biopsies done on 12/07, and then we'll show you what the endoscopy looks like 3 weeks later. All of these biopsies and endoscopies will be 3 weeks apart. All right. All right, this is her endoscopy 3 weeks later, and as you can see, it is completely normal. See an arborization of blood vessels, no inflammation whatsoever, and her biopsies will be shown by Dr. Pat Dean. Oh, excuse me, this is 6 weeks later, and it's all still completely normal.
The pathology here mirrors the endoscopy really to a T. On the left-hand side, as you look at it, you see typical moderately active ulcerative colitis. I'm sorry. Okay. With a dense plasma cell excess in the lap. What am I doing wrong?
If you tap it, it's going to think you're trying to.
Okay. I can just tell you know, if you look on the left hand.
Report to the main information desk.
If you look on the left hand side, you see moderately active ulcerative colitis, a dense mononuclear cell excess in the lamina propria, distortion of cryptarchitecture, and multifocal neutrophilic cryptitis, which is there, but obviously at this power you can't see it well. The point here is the contrast between the left-hand side and the right-hand side, pre-treatment and post-treatment. 3 weeks later, if you look on the right-hand side, the mucosa has returned to a near morphologically normal state. There's a full complement of goblet cell mucin. The chronic inflammation in the lamina propria has been cleared out, and there's no neutrophilic cryptitis. Quiescent disease, moderately active on the left to quiescent disease on the right.
All right, the second case is a 44-year-old woman who's had ulcerative colitis since 1994. It began with recurrent rectal bleeding and cramping that would occur every 6 months for a few weeks. Each episode abated spontaneously without therapy. It began to increase in intensity in '02, and in October of '03, she had a colonoscopy, and for the first time an official diagnosis of UC was made. She was begun on acecol 2.4 grams daily, but still had recurrences. However, they were shorter for a while, and they seemed to occur and last for about 6 months. She then indicated that she would have 6 months of symptoms and then 6 months without symptoms. During this period of time, she continued her acecol at that same dose, but also used hydrocortisone enemas. In April of '07, after a move from Destin, Florida to Memphis and being under a moderate amount of stress, because of the move, she had a very severe episode that did not respond to either acecol or hydrocortisone enemas. She was then treated with prednisone and would take it for about a week and then stop it. When she did this for 3 times, she was then given a dose of prednisone that lasted 20 days. She did well for about a month, but then in July it recurred and was more severe than ever. She didn't refill her prescription, and that's when I saw her and did my initial endoscopy. The endoscopy, again, as you can see on the left side, the 4 slides show what I consider to be moderately active or severe UC. I went up to about 40 centimeters, and again in the mid-sigmoid, it was completely normal. 3 weeks later, as you can see, it is absolutely normal. No abnormalities whatsoever, good blood vessels, no inflammation.
Again, this gets a bit repetitive. Happily, it gets repetitive. On the left-hand side, you see pre-treatment biopsies, striking architectural distortion, dense mononuclear cell expansion of the lamina propria. If you look on the left-hand side and the right-hand side, that is not biopsy artifact. That is actually surface epithelial sloughing of moderately active chronic ulcerative colitis. Then you go to the right-hand side, and this is post-therapy. Now, there is, in fact, a modest degree of mononuclear cell excess in the lamina propria, but if you concentrate on the glands, the mucin is coming back almost to a full degree, and there is no neutrophilic cryptitis, ergo quiescent UC.
The next case is a 44-year-old white male physician who was seen originally in January of '07 with a 20-year history of ulcerative colitis. Let me tell you from the beginning, this is my most difficult patient only because he wound up treating himself many of the time and became somewhat difficult. Nonetheless, he was originally thought to have Crohn's disease, but subsequently a firm diagnosis of UC was made. Over the years, he treated himself with prednisone, 5-ASA drugs, and 5-ASA suppositories. Colonoscopy in January of '07 revealed active disease to 18 centimeters with an inflammatory polyp at 60 centimeters. And his biopsies showed UC. Over the next 11 months, he used prednisone, 5-ASA suppositories, and orally, and continued to complain of significant tenesmus, lower abdominal pain, and soiling. He was under a great deal of stress because of the activity of his medical practice. That's when I saw him. This is his endoscopy, which shows fairly significant disease. Over on the right, you can see some true erosion. A little unusual. That's when I thought it might have been Crohn's, but as you'll see, the biopsies in just a second will show it. 3 weeks later, he's absolutely normal. There is healing, and I'll show you in a second. He does have some residual of the superficial erosions. They're smaller and obviously healing. This was 6 weeks later, again normal except for those erosions.
On the left, again, moderately active UC. This issue of Crohn's disease, in my estimation, it's simply not Crohn's disease. There's diffuse inflammation, striking architectural distortions, dense mononuclear cell excess in the lamina propria, and this villiform configuration of the architecture with crypt abscess formation. A picture being worth 1,000 words. You look at the left, you look at the right, dramatic improvement going from moderately active disease to quiescent disease.
And by the way, clinically, he was dramatically improved and happier than he's ever been. The fourth case is a gentleman who developed bloody diarrhea in 94. Flexible sigmoidoscopy at that time revealed proctitis to 30 centimeters. He was initially treated with azulfidine. He did very well, but never had a complete remission. In 97, enemas were added, and he took them sporadically. In 88 and 99, he was doing well with normal stools and no blood. Azulfidine was decreased, and he was put on PRN, most rosacea enemas. Shortly thereafter, he had intermittent symptoms and evidence of recurrent active colitis. It continued until 03. He then took his medicine more actively, and in 04 there was quiescent disease. Disease activity again recurred very rapidly within a month or so, and he was switched to Colizol, but continued to have symptoms. Sigmoidoscopy in 06 showed moderately active disease. He continued therapy with no significant change in symptoms or findings until 12 of 07 when he was placed on the study medication. His endoscopy again endoscopy again shows significant disease at 3 weeks, and 3 weeks later, after being on therapy for the first time ever, it looked almost perfectly normal. There was definitely some vascular distortion in some of those pictures, but basically there's no evidence of activity whatsoever. That's 6 weeks later, and it continues to be normal. And I'll tell you in a little while that they've all continued to be normal.
If you look on the left there, this in my estimation as a gastrointestinal pathologist, this is pretty extraordinary, striking stuff. If you look on the left-hand screen, there is just dense chronic inflammation in the lamina propria, from the superficial lamina propria right down to the muscularis mucosae, crypt abscess formation, architectural distortion, and then you look on the right, and you know what's happened here. There remains the a minor degree of architectural disarray that characterizes CUC, but there's virtually no mononuclear cell excess in the lamina propria, and you see the full complement of goblet cell mucin and no neutrophilic infiltration. This is quiescent dormant disease.
The last case I think is the most striking, because this patient was sent to me by a gastroenterologist in Oxford, Mississippi, basically as a second opinion for surgery. He's a 39-year-old white male diagnosed with UC at age 13 in 1981. Apparently did well and was seen by a gastroenterologist in Oxford at age 26 when he was found to have severe disease. Most of his disease was rectosigmoid, but there was spotty disease throughout the rest of the colon. During the next decade, he was treated with prednisone, azulfidine, Imuran, Rowesa, Acecol, Entecort, and finally infliximab, Remicade. During these years, he was almost on chronic steroid therapy. His disease waxed and waned, but rarely, if ever, went into complete remission. The Remicade was given in the years 03 and 04, but then stopped when it didn't appear that he was responding. He was restarted in 07, but he didn't respond again. In August of 07, he was found to have severe proctosigmoiditis, which was severely altering the quality of his life, and surgery was considered. He was referred to me at that time for a second opinion regarding surgery, and at that time, disease was seen to 50 centimeters. His endoscopy again shows moderately active to severely active disease throughout, and 3 weeks later, and I must tell you, when he came back 3 weeks later, and I'm not, this is not hyperbole, the guy was crying. It was the first time in 10 years he had normal bowel movements. And as you can see, there's certainly evidence of some scarring and vascular distortion, but basically a completely inactive disease, no friability, nothing. You finally can see blood vessels, and that continued. Here, even 6 weeks later, you can see blood vessels a little bit better, completely asymptomatic.
Well, again, you look on the left, and we can argue here whether this is moderately active or severely active ulcerative colitis. But whatever it is, it's big-time activity in CUC. And then you look on the left, it's difficult, I'm sorry, on the right, it's just difficult to believe it's the same patient. I mean, look at it. It's striking. It is absolutely quiescent disease with regeneration of crypts. Granted, the architectural distortion that we typically see with dormant disease, but, you know, everything's cleared out on therapy.
This clinical case presentation demonstrates that a new treatment aimed at reducing colonic hydrogen peroxide, which the evidence identifies as the cause of ulcerative colitis, is highly effective in achieving complete remission and healing of ulcerative colitis regardless of severity, and can bring about a cure. This is exactly what you would expect if you are targeting the true underlying cause of disease with the appropriate treatment.